only want to look at a couple rhythms, okay? It's Friday. They tell me not to do a lot on Friday.
Tuesday.
Not in school. Life tells me not to do a lot on Friday. Relax and get ready for the weekend, right? Okay, so Wpw Wolff-Parkinson-White Syndrome. It's a syndrome. Anytime you hear syndrome, it's because they don't know what's causing it, right? I was going to tell you about this the other day, but I couldn't remember why. I couldn't remember the background Wpw, okay? So I had to make it up and say, let's stop here, because I couldn't remember. So I had to pull in some Google here, Tom. Okay, so Wpw, what happens here, it creates an extra electrical pathway or a bypass track. Okay, so it connects the atrium directly to the ventricles by this bypass track. Okay, and in A-fib, if it's associated with atrial fibrillation, it could be lethal. Okay, but we'll get to that in a minute. The atrium contracts sometimes 300 or 400 times per minute. So with this Wpw, sometimes in children, they don't even know that they have it until they get old and they have an EKG done and they see that. Like with some of you guys, I think, when we went and hooked up the EKG machines, right? You have a bundle branch block. You didn't even know it. It's maybe insignificant, right? So they may not even find it. So it could be harmless. What happens if it starts causing problems? They do a procedure called an ablation, A-B-L-A-T-I-O-N, ablation. You hear this on TV a lot. They do the ablation, and what it is, it's through heat. So what in here, they insert a catheter like in the cath lab, and they go up through the heart, and they find that extra electrical pathway, and would ablaze be a word? Mm-hmm. They use heat. They burn it away. Okay? They do a lot of that with, what's this procedure they do? They, like hysterectomies, or polyps. Yeah, they do different things. I don't even know if the term is correct, ablaze, but they do the ablation, right? You'll hear that a lot in the OB section. They do that, okay, with polyps and cysts and different things, okay? But on the EKG, the Wpw, they developed this delta wave, okay? In this delta wave, if you notice right here, that's that T wave from the other one. And then it has this sort of weird slope that comes up. It doesn't come up straight off the isoelectric line like a normal EKG. And that's how you would recognize that this is Wpw, by this S wave. Okay? Everybody good? That's it. That's all I want to talk about. Wpw, because it is rare. You may not even see it. Another rare one is atrial flutter. Okay? It produces F waves. I think that's what they call them. That's what I'm going to call them. F waves or shark tooth waves. Okay? So you have the different types, but flutter. Okay? It's an atrial rate between 250 350. Okay? Mm-hmm. It's a re-entry conduction problem, like we talked about, like an SVT. True atrial flutter is very rare, okay? And you see what you have here is the rate, the atrial rate, 250, 450, depends on how many, okay? And then no discernible P waves, but you have this sawtooth, I called it a shark tooth, didn't I? Mm-hmm. Sawtooth flutter wave. I think they really term it as S waves, but a picture will tell you 1,000 words. So these are not P waves, obviously, right? See, there's two of them. This would be 1, 2. This might be. It looks like there's only two. This might be a T T wave. But there's two of them, right? There's two distinct. So it's a 2-to-1 atrial flutter, meaning there's two F waves to one QRS complex. There could be 3 F waves or 4 F waves. Obviously, the more F waves or the flutter, the sawtooth waves, okay, the faster the atrial rate, okay? It is probably one of the easiest rhythms to recognize besides A-fib, okay? The rate is regular, okay? The QRS complexes are normal, but there's F waves. So when you see that, you see those sawtooth waves, you go, oh, that's flutter. And it's 1 to 2, 2-to-1 flutter at a rate of a ventricular rate of 1, 2, 3, 4, 5, 6, 7, right? So you're going to feel a rate of 70-ish, okay? You can't feel the atrial rate. So you'll feel this rate of 70, but on the EKG you'll notice that it's a 2-to-1 flutter, but rare. I think I've only really seen it a couple of times, okay? And it's only significant really when the ventricular rate is increased. All right? Make sure I didn't miss anything. You don't measure the PRI because there's no P waves. Okay, we're just really concerned with the rhythm interpretation, and that's it. Once you see the sawtooth waves, it's an atrial flutter. Then to be correct about it, you say 2-to-1, 3-to-1. Okay, so all of a sudden here, PCT land, you're in a sinus rhythm. Okay, and you go in and you look up and you go, oof, that's not a sinus rhythm, correct? What would you do? Atrial flutter, you know? Okay? Everybody good with that? Pretty easy to go along. The next one is atrial fib, the same way. People, now this is common. Atrial fib is very common. So this is a very common rhythm in a sinus rhythm, okay? A patient that was in a sinus rhythm is now in A-fib. Really quickly tell the nurse that, hey, the patient went into A-fib. A-fib, people in atrial fibrillation, and you can pick this up off the commercials, they're more likely to go in and have stroke because those atrium, I got to show you that video, it's really cool. Those atrium are fibrillating. They're doing this, okay? And so that's just sort of common sense. The brain causes stroke. Atrial fib. So the rules of interpretation, the rate, the atrial rate, okay, up here like this, it's fibrillating, it just shakes. Ventricular fibrillation, what's shaking? The ventricles. Ventricular fibrillation is life, it's a lethal rhythm. Okay, it's shockable. That's V-fib. No. Why?
Because it's not on the QRS.
Very good. It has QRS complexes. It's not V-fib. If you took these complexes out, V-fib, you would hit the code button. If you saw that, you say, we have a code. We have code blue. Boom. Hit code blue. Because the patient's fibrillating. It's lethal. Okay, but this is A-fib. There's no discernible P waves. Don't try to, this is what I was telling you earlier, don't try to make this a P wave. That's not a P wave, okay? This is crapocardia right here. There's just nothing, it's chaos. Okay, so don't try to put P waves in there. So no discernible P waves, no, okay? It's always irregular. So if you're trying to decide, is that a sinus rhythm? If it's irregular and there's no discernible P waves, it's not a sinus rhythm. It is atrial fib, fibrillation. See how easy that is to interpret? All right? So no problems there. So you look at that rhythm and you say, QRS complexes, 1, 2, 3, 4, 5, 6, 7, 8, 9. And it's obviously irregular because the distance between this R wave and this R wave is different between the distance between this R wave and this R wave, right? So you can see it's irregular with no discernible P waves. Boom! A-fib. Don't have to make a lot of decisions, right, with that. Okay, so we go to this. We go over here and we say, okay, atrial fibrillation. You can have A-fib with a rapid ventricular response, AVR. Okay, what does that mean?
What do you mean by what does that mean?
What does that mean? What's a rapid ventricular response?
Your ventricles are starting to make up for the fact that your atrium
Huh?
aren't.
The ventricles are going to contract fast?
Which would give you more what? In
QRS.
QRS complexes, right? You guys overthink everything. So you're going to have this A-fib, okay? 150, it's considered an AVR. It's considered A-fib with rapid 100, right? 60 to 100 with AVR, RVR, rapid ventricular response. Okay? So, risk of stroke. So we need to slow it down. This is where we get to this. Cardizem. This, you wouldn't give the medicine that you would for, okay, so it'd be a different medicine. And it's called cardizem. If you can pronounce this, go ahead. Yeah, that's the other name. See, I picked the one I can pronounce. So I can pronounce cardizem. This one, I don't know, right? It's sort of like methylpterenol. So, yeah, this is the same. This is one name. Cardizem is one name, and this other name is the second name that it has for it, okay? So, methylpterenol. Who wants to say that? All right? You try to say it too fast, you sound like Daffy Duck. Methylpterenol, right? So, you go in there, and so I say low pressure. It's the same medication, right? So, but I know both in my head. Okay, so if I see this on paper, I go, oh yeah, that's cardizem. If I see this, I'm like, oh yeah, well that's that, you know. Yeah, who knows, right? So, diphenhydramine is what? Yeah, Benadryl. If you want to be impressive, say, well, I think you should take 2 diphenhydramine. And they go, Take a couple Benadryls, right? Yeah. Or you might say, do you have pruritus? That sounds like, oh, heck no, I don't have pruritus. What are you talking about? Itching. Pruritus is itching. My new favorite word, okay? So, what cardizem is, okay, is a calcium channel blocker. That's the class of drug that cardizem is. It's a calcium channel blocker. So now, where this is important for you guys, is that when we're doing our patient assessments over here, and I throw up A-fib at 150, hey, I think we need to probably give this patient some cardizem, and you're going to need an IV for it because it's given either intravenous as a bolus, meaning it's all at once, or they do a drip. Most of the time what they will do is they will do a maintenance drip where they will drip medication in it through a pump to keep it slow. Okay? The same way with the bradycardia. They will bolus and then do a maintenance drip. Everybody good with that? Okay. But cardizem is the medicine of choice for a atrial fib and the heart rate. You cannot give cardizem to an SVT. That's why rhythm interpretation is so important. If this was at a rate of 100, it would be fatal for the patient. That's the importance of killing your patient, okay? So, we'll flip back to the SVT in just a second. Headaches, CHFers, very common, okay? Very easy to recognize. You see this in the emergency department. You see hey, you'd be standing around there and say, hey, y'all don't give some. Other thing that they can do as well in an unstable patient, they can do what? A-fib, AVR with RVR at 180. What can they do? Shock it. Synchronized cardioverted it.
Oh,
Mark out those R waves and shock it, right? Which they will do. Alright. One more thing, I'm just going backwards here. So now decimal means it's come and go. But we have this SVT here. This is sinus because it's what? The SVT part of it is what? It's regular, right? It's regular. That's the way that we can't see those P waves, okay? But it's regular, so it's not A-fib. It can't be. It's an SVT, supraventricular tachycardia, above the bundle hit adenosine. They gave it just the other day in the ER. It's cool. Remember, we talked about it. Puts the patient in a ventricular standstill. Puts them in the asystole. So you have all these complexes. Well, that's VTAC, but that's sort of. I draw it poorly because we're running short on time. And then you give the adenosine. It's going to put them in a period of asystole. Okay? Then what we hope to happen. That's right. Their rate to slow down. If it doesn't slow down, they become critical. They're going to shock it. Okay? But the medicine for that is adenosine or adenocard. It's the other term for it. It blocks AV conduction. Okay? The class of drug that it is it's an anti-arrhythmic drug. Because this is an arrhythmia. Okay? SVT is an arrhythmia. So it's an anti-arrhythmic drug by blocking the conduction in the AV node. It's a re-entry conduction problem, right? So, if you have this SVT, the problem with adenosine is it has a 15-second half-life, meaning it's over in 15 seconds. The medication is not working after that. So it's a very, very quick half-life. So they can also give a calcium channel blocker to an SVT, right? They can do that. They can give a calcium channel blocker. There's a bunch of them, just not Cardizem. They give a bunch of them. But probably what they're going to give is a beta blocker to this. If this is not working and the patient's still stable, they're going to give that patient a beta blocker to slow the beta responses down. Remember, beta 1 responses increases the heart. They're going to block that to slow it down. Okay? It's very, very similar to a calcium channel blocker. It's just a different way of working. It doesn't block the calcium channels. It blocks the beta receptors. Okay? In here, so adenosine. So in our patient assessments, if I give you a rate of 200 in SVT, we know that we're going to have to start an IV on Steve, and we're going to have to give him some adenosine. Or, if your patient's unstable, this is going to add some scenarios to us now. Okay? If he's unstable, like the patient was the other day at 212, 220, then we're going to shock it. We're going to synchronize cardiovert. We synchronize both with A-fib and SVT. We start the synchronized cardioversion at 50 joule watts to 100 joule watts. Okay? We defibrillate at 300 joule watts. See the difference? It's not quite as much, but this is conscious. This patient's conscious. They're going to give them a sedative because it hurts like crazy, what people tell me. Not that I ever want that, but it hurts. They yell and scream because it hurts. They're being electrocuted. Okay? So the electricity works the same way as the medicine, but it stands still as the heart. The heart picks back up its normal function. Okay? That's what we want to happen with the SVT. Okay? Everybody good with all that for Friday? Okay. Next time, week after next, we will start with junctional rhythms. Very easy to interpret, no key waves. Okay?